Hello. Thank you very much for inviting me to come and speak today. And also thank you very much, perhaps more importantly, to all of you for coming to listen. Today, I'm going to be talking about the complications of the hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder that are autonomic related. In other words, I'm going to talk about PoTS, vasovagal syncope, and a little bit about orthostatic hypertension. You'll probably see me slipping back into the old terminology from time to time because actually the research that was done used that technology at the time, and it also used that diagnostic criteria. It's not yet clear how much of it applies to the new terminology because it hasn't been tested yet. And it's also not very clear how much of these autonomic conditions apply to the rarer forms of Ehlers-Danlos syndrome and other hypermobility-related conditions because the research hasn't been done yet. So in addition to talking about these conditions, I'm going to focus perhaps a little bit more on the management of them, and then I'll finish up by discussing a little bit about how to find help if you think you have these conditions. Okay, so having dysautonomia is actually challenging, but it's probably equally challenging to understand them. It's quite a complex issue, even for healthcare professionals. The autonomic nervous system is the nervous system in our body that controls the functions that we don't have to think about. So that includes things like breathing, digestion, and heart rate control and blood pressure control. When you have autonomic dysfunction, sometimes also called dysautonomia, this autonomic nervous system isn't working properly. Now that can happen in lots and lots of different conditions. It happens in diabetes, it can happen in Parkinson's disease, and other conditions not related to hypermobility. When it does happen in relation to hypermobility, it often causes orthostatic intolerance. And orthostatic intolerance is intolerance of being able to stand up, or the definition is also sometimes said to be symptoms in the upright position that are relieved by lying down. And in hypermobility, this tends to manifest itself as three syndromes. One of them is postural tachycardia syndrome, another one is orthostatic hypertension, and the third one is vasovagal syncope. Now, some patients can have just one of these, and some people can have two, and some people can have all three. It's sort of a spectrum that kind of merges into one another. And sometimes people get quite worried about, they might be given a diagnosis of PoTS, they think they've got orthostatic hypertension or vice versa. But actually, at the end of the day, it probably doesn't matter too much in most occasions because the management of them is similar. So how often do we find dysautonomia in the joint hypermobility syndrome? So there was a neat little study done in Israel, and Professor Graham was involved. And what they did was they took a group of patients with then joint hypermobility syndrome and a group of unaffected healthy controls. And what they found was that all the patients with joint hypermobility syndrome had orthostatic intolerance. They didn't like standing up because they were symptomatic. And then they also found that over half of the joint hypermobility patients fainted. About a fifth of them had postural hypertension, and 15% of them had postural tachycardia syndrome. Now, I'm going to turn that the other way around and say how many patients with PoTS have joint hypermobility. And what we did was, the charity in association with some universities in England, we did a big survey of PoTS patients, and some of you here might have actually participated in that. And what we found was that approximately half of them had been given a diagnosis of joint hypermobility syndrome, Ehlers-Danlos hypermobility type. Now, that's just the number that had actually been given the diagnosis, and I know that in quite a lot of the centres where they diagnose PoTS, they don't even think about associated conditions. So we suspect actually that the number is a lot higher. And some of the larger centres in London, they're actually quoting figures of around 90% of their patients because they screen for it. Okay, so how does this come about? What happens when a healthy person stands up? Well, initially, about a quarter of your blood volume wants to drop straight down into your abdominal cavity and down into your legs and arms. But your body responds instantly by narrowing your blood vessels, and then your heart rate beats just a little bit faster, up to about 20 beats per minute. And that helps the blood to be pushed back up to your heart and onto your brain. But in these conditions, the autonomic nervous system doesn't work properly, and this vasoconstriction, this narrowing of the blood vessels, doesn't work efficiently. So blood tends to stay down in the abdominal cavity and in the limbs. And you can see this as something called acrocyanosis. So these hands and feet, the dark-coloured one has been dependent and the light-coloured one was horizontal, and then they were just put together for the photograph. But you can see this puffy sort of purpley discoloration that's called acrocyanosis, and it's due to pooling of the blood. Okay, so this is orthostatic hypertension, and it's defined as a drop in blood pressure of 20/10 when you stand up. It's probably, the recordings are not important. What's actually more important is whether or not it causes you symptoms. The symptoms can be very, very similar to PoTS, although maybe the tachycardia and the palpitations are a bit less prominent. And as I said before, the two conditions can coexist. And you can see in that diagram there, the darker line at the bottom, that's the blood pressure, and you can just see that tailing off, and it happens usually over a few minutes. So that's vasovagal syncope. That's another tilt test diagram, and you can see that in that one, the blood pressure and the heart rate remain relatively stable. And then suddenly at the end, there's an almighty crash in both the blood pressure and the heart rate, and the patient passes out. So that's vasovagal syncope. Now, in PoTS, to have PoTS, the consensus definition, that's really just by agreement, is that you should have a sustained increase in heart rate of over 30 beats per minute on standing, and that should be associated with symptoms of orthostatic intolerance. That's your pre-syncope symptoms, the symptoms that people experience just before they faint. And in PoTS patients, the commonest three symptoms are fatigue, palpitations, and lightheadedness. You can see that there are a lot more symptoms as well. And these are generally thought to be due to altered circulation to the heart and the brain, and also to raised adrenaline levels, because patients with PoTS often have quite high adrenaline levels when they're upright compared to when they're lying down. And that's the tilt table test printout of a PoTS patient. So the one on the right is the control, and the top line's the heart rate, and you can see that as the tilt progresses, the heart rate just goes up a little bit, about 20 beats per minute, and the blood pressure is quite stable. In the PoTS patient one, on the left, you can see the top line, the heart rate rockets up to about 180 in this instance. And the blood pressure, although it doesn't drop, it's relatively unstable, and that's very characteristic of PoTS. It's a condition that tends to affect women between the ages of about 15 and 50, and like many of the hypermobility conditions, it's often called an invisible disease. Patients can look reasonably well, but they can be very, very disabled by the condition. And the mean time to diagnosis in the UK is about 7 years, and in the interim, at least half the patients are diagnosed with psychiatric conditions such as hypochondriasis, depression, anxiety, and panic disorder. But it's really important to pick it up, because if you do and you correctly treat it, then about 90% of patients will significantly improve. PoTS doesn't just occur in relation to hypermobility, it actually can occur in relation to a number of other conditions. I won't focus on them today, but it's quite common in association with chronic fatigue syndrome, and it also occurs in autoimmune conditions. Okay, so how do you manage PoTS? And much of what I'm going to say here is also applied to the management of vasovagal syncope and orthostatic hypertension. There are subtle differences. I mean, if we could stay upside down like these sloths here all day long, we wouldn't have a problem, but that's not going to happen. So first of all, we have to avoid triggers. If you're on any medication that reduces your blood pressure, then you should consider stopping them. And this is actually quite problematic in the hypermobility setting, because patients are often in a lot of pain and they're taking drugs like amitriptyline, pregabalin, gabapentin, Lyrica is the other name for it's gone out of my head, I've just said it. But pregabalin, thank you. And these can all lower your blood pressure. So sometimes it can be helpful to reduce your symptoms to stop them, but sometimes you can't because of your pain, and you just have to find the right balance between the two. Avoid prolonged standing and sitting. Avoid heat and alcohol, because both of these can dilate your blood vessels and cause your blood pressure to drop and your heart rate to increase. Exercise is quite a contentious issue in PoTS. There is a group of people, particularly in the USA, who propose that PoTS is actually due to deconditioning or lack of fitness. In our study that we did of over 1,000 patients with PoTS, we found that the majority of them were actually getting regular exercise before they were hit with their PoTS. So we feel that in some people, because they feel so awful when they exercise with PoTS, that stops them from exercising, and therefore they become deconditioned. So if you are trying to rehabilitate with PoTS, then I would always advise the patient that it's going to take a minimum of 6 weeks to make a difference, and that they're probably actually going to feel worse in the meantime. And very often you have to start at a really low level, and that might just mean strengthening your core muscles from your bed. If you're able to progress from that, then Pilates is quite useful. That's something that can often be done in a horizontal position. Also, swimming, recumbent exercise, biking, and rowing can be helpful. But again, in the hypermobility setting, you often have to make special considerations because of the pain and the joint problems that patients have. So, for example, if you can find a Pilates instructor who's knowledgeable about hypermobility, that's very useful. And with swimming, a lot of people do actually find swimming difficult. It's not the swimming itself that's often the problem, because the water helps you to combat gravity. It's often the getting out the pool afterwards and getting changed, and by the time you've done all that, you feel rubbish. So when you're swimming, as with other forms of exercise, it's really important to wind down afterwards slowly. Maybe float at the side of the pool, sit on the steps, and then when you're having a shower, have a cool shower. And then if you're going to the changing room, have everything ready. Try and sit down when you're getting changed, and then get out the hot changing room as quickly as you possibly can. Pacing is also important. If people have a good day, they've got a few extra spoons, they want to spend them all at once. But then you end up in a sort of boom and bust situation, and you find that you're exhausted for 2 or 3 days afterwards and you can't really function. So I'm not going to go into that in too much detail because I know that there are going to be other talks on that during the course of the next 2 days. Fluid intake. Patients with PoTS and many patients with orthostatic hypertension and vasovagal syncope are what we call hypovolemic. And what that means is that if you will, the blood vessels are perhaps a little bit too stretchy, so their capacity is bigger than the volume of the blood. So what you want to do is to try and expand that blood volume by drinking more fluids. And we would normally recommend in an adult 2 to 3 litres a day, as much as possible, even before you get out of bed in the morning. And if you're doing exercise or you're in a hot climate, you might even need more than that. Children, obviously, with their different size, have different requirements. So we usually recommend that children drink fluids until their urine is running a pale straw colour. Rapid water drinking is interesting. That means drinking 2 glasses of water or other fluids rapidly in quick succession. And what that does is it stretches your stomach, and there's a reflex that raises your blood pressure and reduces your heart rate before the fluids even got into your bloodstream. So that can be useful in a sort of emergency situation. We usually recommend increased salt intake because when the salt gets into your bloodstream, it helps to sort of suck the fluids into your blood and keeps the water in there, again, to boost your blood volume. And whilst I wouldn't recommend as much as this chap's enjoying in this picture, we would normally suggest that you have about an extra 6 grams of salt a day. And that's about the same as a level teaspoonful, which is the same as 10 slow sodium tablets. It's not suitable for everyone because people who have heart conditions, kidney conditions, and hypertension, which is sometimes associated with the hyperadrenergic form of PoTS, they have to be really, really careful about their salt intake. Now, I'm not sure if you can read that, but it says, but then after eating the porridge, all those carbs kicked in and Goldilocks had to lay down and take a nap. Now, that may be a bit of a joke in this picture, but that's real life for people with PoTS and orthostatic hypertension. What happens is if you eat a meal that's high in refined carbohydrates, such as cake, white pasta, white bread, then the blood's diverted to the gut to try and digest it. And what that then does is it takes the circulation away from your heart and your brain. So people, sometimes quite soon after a meal, sometimes it's delayed for an hour and a half, but they often feel lightheaded, have to lie down, feel really tired, and some people even faint. So what we recommend is a low GI diet in that situation, a low glycemic index. And that means basically your brown carbohydrates, brown bread, brown pasta, if you're eating them, lots of vegetables, a lot of protein seems to be helpful as well to some people. And the other thing that's very useful is to eat little and often. And it's quite interesting because a lot of people with PoTS and orthostatic hypertension, before they've even got a diagnosis, find that they're actually eating 5 or 6 times a day. So the idea is that you have half a meal, but twice as often. Now, compression has been found to be useful in orthostatic hypertension, low blood pressure. It squeezes the blood back up to the heart, if you will. And so they've kind of applied that to PoTS. It's never really been studied or tested, but some patients anecdotally find that quite strong compression tights, they have to be waist high, are useful. Not everyone can tolerate them because A, they're uncomfortable, and B, they make you hot. And also, they're not particularly attractive. But there are new ones coming out. They're not available on prescription, you won't be surprised to hear. And also, for men, sometimes they find that the sports compression are a lot more acceptable, and quite a lot of young women and older women are wearing these too. Postural manoeuvres can be quite useful to avert a faint or a near faint episode. And what you're trying to do is to activate the muscles in your body because they act a bit like a second heart and help to pump the blood back up to your heart and brain. So the sort of things that you want to try doing are, I'm not sure if you're going to lose me now, but you want to stand with your legs crossed like that, and then squeeze your thighs, squeeze your buttocks. You can fold your arms and squeeze them. So these are things that you can do quite subtly, like if you're standing in a supermarket queue. Even holding your arms like that or making a tight fist can help to raise your blood pressure. Again, if you're wanting to be subtle about it, then squatting down can help to raise your blood pressure, and you can just sort of pretend you're rummaging in your handbag or you're tying up your shoelaces. But sometimes you can't be that subtle, and actually, if you're having a real proper pre-syncope, the only thing to do is to lie down flat on the ground, get your legs up in the air, and kind of ride a bicycle with your legs to try and avert it. Tilt training is something that has been studied in vasovagal syncope and in orthostatic hypertension. And what that does is it resets something called your baroreflex, and it helps you to tolerate standing better. So this can either be done at home or on a tilt table in a hospital, and patients are tilted for increasing lengths of time, and they just basically have to stand there. It's incredibly boring. Some people feel rubbish and some people faint. So you have to be really, really committed to actually make this work. And like I said, it's not yet been proven, although it's an interesting idea to work in PoTS. Now, CBT can be helpful. If you've been somebody who's been kind of batting around the health service for years and years, being told that you're mad and all your symptoms are in your head, then being told that you should have CBT doesn't always go down well. But actually, what we're suggesting here is not for someone to tell you how to manage these imagined symptoms. It's actually about helping people to adjust to a new chronic illness, to perhaps grieve for the person they were before and try and find positive things in the way that they're finding themselves now. Also, particularly in PoTS, you can get some real scary symptoms like chest pain and breathlessness, and CBT can help you to manage these symptoms a bit better. Now, once you've tried all these lifestyle changes to help with your PoTS, orthostatic hypertension and so on, we normally would suggest trying it for about 2 to 3 months, but it depends on how badly affected the patient is. Then medication can be helpful. And that's an overview of the drugs that are used in orthostatic hypertension, vasovagal syncope, and in PoTS. And there isn't really much time to go into all of them in detail, but I just want to highlight the ones in the middle there because they can be used in all 3 conditions. And that's midodrine, which is called an alpha agonist. And what that does is it narrows your blood vessels and helps to squeeze the blood back up to your brain. And then the fludrocortisone, that helps you to retain salt, and therefore that sucks in the water to boost your blood volume. But if you want to know about any more of these drugs, I'm happy to take questions on that later. Now, there's been a growing trend in the USA for intravenous fluids. And a lot of people are now asking the consultants in the UK if they can have a permanent line in and have regular intravenous fluids. And there's no doubt people feel a bit better after an infusion. So far, I mean, I know there's been a couple of studies, but they've not been particularly good ones, and they haven't been controlled studies. So there's no evidence yet that this actually works better than drinking fluid. Now, I know some people with hypermobility have gut issues, and actually being told to drink 2 large glasses of water quickly is an impossibility for them. But in general, I would say that really the intravenous fluids should be reserved for kind of emergency situations like gastroenteritis and hyperemesis, vomiting in pregnancy, and so on. Okay, so what should you do if you think you might have PoTS or orthostatic hypertension or vasovagal syncope? Well, the first thing to do is learn a little bit more about it and then take your concerns to your healthcare professional. Now, you won't be surprised to know that quite a lot of them don't know much about this, so it might be worth taking a printout either from the Hypermobility EDS charity websites, because they've got very good leaflets there on autonomic dysfunction. And we've also got leaflets on the PoTS UK website about this. We've actually got a guide for GPs, and there's also another one called Living with Low Blood Pressure, which you might find helpful and which the GPs might find helpful too. In the setting of hypermobility, if you've got the correct symptoms, actually a stand test, which is sometimes called the poor man's tilt test, can be enough to diagnose PoTS. But if there's any doubt about it, then a tilt table test can be helpful, and it's particularly helpful for ruling out other conditions. Once you've tried the lifestyle changes, and they perhaps haven't worked as well as you would have liked, then it may be necessary to seek referral. And I would suggest that you try to find somebody who's actually got an interest in this sort of problem, because being referred to a general cardiologist can sometimes be quite a soul-destroying experience. We do have a list of specialists with an interest in PoTS and syncope on the PoTS UK website. And that's our website. At the top right, it used to say doctors, but it now says services as of a couple of weeks ago, because we've started to list other healthcare professionals as well. Okay, so there's probably not much time for questions now. I'm happy to take any, but I'm going to be around all day, so if anyone wants to ask me anything about it, please feel free to find me at this stand. And I'm also really pleased that we've got Kate G here. Kate, or Dr. Kate G, is a nurse consultant at the Queen Elizabeth, and she runs the PoTS and syncope service, and she'll be at the table with me. So if you want to ask any of us any questions, then please feel free.